umbilical, and there's intervening periods of usually their health, the normal behavior, normal activities. But then here they can have any two of the following. They can have nausea, vomiting, anorexia, headache, photophobia, or pallor. And again, if it is there, it has to be there at least 2 times in the last 1 year. Then you can say this is abdominal migraine. So I mentioned about dyspepsia. I mentioned about irritable bowel syndrome. I didn't mention about abdominal migraine. But then you have a group of children, when you have pain lasting for 2 months or happening at least once a week, but they don't fit of any of the three criteria, then you can use the word functional abdominal pain, not otherwise specified. So these are the major 4 functional abdominal pain categories. So what I am trying to say is, as I mentioned earlier, in another 10 years, probably Rome 5 criteria will be there. I mean, another 5 years, I mean. So, which is going to call us disorders of gut-brain interaction. And you may not be able to hear the word functional GI disorders at that point of time. I just want to briefly say that we did present our study in an European Society annual conference last year as an oral presentation. I just want to give a summary of our study because I don't have time to go in detail. We did say this, we did found that it's a positive diagnosis which helped us limiting the extensive investigations. And in the infant toddler groups, we had again majority of the functional constipation, then followed by regurgitation. In the children adolescent group, we had a functional defecation. This was a very common problem. And then we had functional dyspepsia among the functional abdominal pain, the most common problem. We noticed 65% of children have missed their school, from few days to few months. That 4% did have underlying psychiatric illness. And interestingly, in around 1/3 of the patient, there was an overlap of functional GI disorders. This is very important for you all to remember that. So, okay, you have a child presenting to you. How do you go about in your clinical practice? You have, let me briefly say about case scenarios. I'm not going to go in detail about the cases. Let us have a case one which is common to the epigastric pain and the usual associated symptoms of dyspepsia. And case 2, they have a periumbilical pain and they have they can have constipation. Case 3 is a left and lower quadrant pain and frequent stools. So how do you approach them? Basically, a detailed list is important. You need to have focused investigations on appropriate management. First, you need to differentiate the organic from functional. Main thing is you need to look at the site of the pain and the predominant symptom associated with it. And then depending upon this association, you will be able to arrive at a diagnosis looking at the alarm signals also. So you all know that if there is an organic cause, it tends to be localized, consistent, usually lasts longer and is well defined, and sometimes it can be nocturnal. In functional, it is usually in the midline. It can be periumbilical or could be epigastric or lower abdomen. But thing is, it can be also paroxysmal. They comes and goes, usually short periods, and usually they don't affect the sleep, but they can have an associated somatic symptoms. So this you all know, undergraduate and postgraduate teachings. A, B, C, you all know this is organic, and B, B is lumbar. And when it's type 1, the one number 1 and number 2, epigastric and periumbilical, or the number 3 could be a functional. You cannot, but you have to make sure you rule the organic problem also. And left iliac fossa, nowadays when I have a pain, when I have a child having tenderness there, fecal mass, it is most likely constipation. Always make sure look at the perianal area, apart from genitalia and groin. Don't miss that. And of course, oral cavity exam is very important. So we have epigastric pain. The prominent symptoms look at dyspepsia, which could be bloating, flatulence, or indigestion early satiety. Periumbilical, usually they have only as pain, nothing else. Lower abdomen, they can have an associated altered bowel habits. They could have a mucus or blood in the stools. So if you have epigastric pain with dyspepsia, the chances of the child having an organic problem is around approximately 25%, which could be a reflux disease, an H. pylori, or gastritis, or a duodenitis, or a pancreatitis, or a biliary disease. Whereas it could be functional in around 3/4. And there could be functional dyspepsia, or there could be aerophagia. Periumbilical paroxysmal pain, here the functional component is much more, around 90% it could be. But again, here you can have organic problem like malrotation, adhesions, or rarely food allergies or intolerance can present periumbilical pain. Lower abdominal pain, altered bowel habits. The organic, obviously, they are IBD. They could be tuberculous abdomen. And functional again is 75%. Here, irritable bowel syndrome, or functional constipation. So what are the alarm signals? We all know age in less than 5 years usually it's organic. They have a weight loss which is involuntary. That's very important to know that. We do have teenagers who have voluntary weight loss nowadays. Growth issues, GI bleeding, or a fever, rash, arthritis, or a bilious vomit, or altered bowel habits, nocturnal pain, or a significant family history. Alarm signs again, issues with the growth, delayed puberty, jaundice or pallor, a significant abdominal distension, a mass abdomen, perianal disease. Please look at the perianal area. They could have fissures, fistulas, stacks, joint swelling, or oral disease, because sometimes IBD can present only with, no, or Crohn's can present with only oral disease. What is important when you take the history, also look at the parents. See how they interact with you, how they report the symptoms. They do, there is genetic vulnerability here. There is a high frequency of pain in the family with those who particularly have anxiety, low self-esteem, etc. And overprotectiveness, maternal depression, do have a direct effect on the incidence of functional abdominal pain in children. But of course, look at the child, how they are with it. They're often perfectionists. You all know that one. School absence is very, very common in this group of children. And again, look at the family history. Somatic disorder in the family. So investigations, I'm going to talk it very briefly only. You want to limit investigations as much as possible. Probably if there's alarm signals, I mentioned, you may do a complete hemogram, peripheral smear, and inflammatory markers, and urea, creatinine, LFT, pancreatitis we suspected amylase or lipase. Urine analysis is very important, UTI, stool microscopy, and ultrasound abdomen is very useful tool, particularly fasting one. So the second line is, usually less than 5% needs them. They may need endoscopy. They may need contrast. Radiology does look at malrotation, etc. Celiac serology, particularly from northern part of India, western part of India, particularly from Maharashtra, there is history of gluten intolerance or fecal calprotectin if IBD suspected in other studies. So now I have given you three scenarios. One is case one epigastric pain with dyspepsia as a predominant symptom, and organic chance is likely a bit higher here, especially with the probable diagnosis are given. You may consider level 1 investigations per upper endoscopy. There's a periumbilical pain, they have a constipation, most likely is a functional abdominal pain or functional abdominal pain not otherwise specified, or constipation. You may not do any investigations, or you may just do a level 1 investigations. They have a left lower quadrant, frequent stools, they may have an IBS, but also think about IBD, particularly with alarm signals. Apart from level 1, you may have to do an ileocolonoscopy, plus or minus fecal calprotectin. This is a brief algorithm. The child presenting abdominal pain to you, a history and physical examination. Look at the alarm features. The alarm features, they need appropriate investigations. If no, they're having a functional abdominal pain disorders. And then you try to classify them, the 4 classification I told. Dyspepsia, irritable bowel syndrome, abdominal migraine, and functional abdominal pain are not otherwise specified. Then you manage accordingly. The treatment basically is a broader guideline, I would say. First of all, if you are very sure, you should be very sure you are dealing with a functional GI disorders. Explain and reassure. The one important thing is statement you have to say in front of the child to the family, that you have to say this word: the pain is real, so that the child get reassured. Tell them, however, there is no underlying serious medical problem. And please look at the red flags, particularly avoid NSAIDs and avoid psychological labelings. Make sure they go for normal activity, and make sure you follow them very frequently. And most importantly, remember that if you're going to give any drugs, which I'm going to discuss shortly, it could be just a placebo response. One important thing is regular follow-up, and please make sure you involve the pediatric gastroenterologist. Drugs, very briefly, you could consider H2 receptor antagonists or PPA with predominant dyspeptic symptoms. Again, for a short period of 3 to 4 weeks, don't keep on giving it. You could consider pizotifen, abdominal migraine. You could consider peppermint oil in irritable bowel syndrome. But most of them is functional. They may not need any medicines apart from constipation treated aggressively. One important thing I mentioned earlier, chronic abdominal is a fluctuating condition, and any response may be just due to the placebo effect. So this was the medicines I told you. I don't use them antispasmodics at all, honestly. They do not have very strong role in functional abdominal pain. Tricyclic, maybe you consider there's an anxiety, underlying anxiety, but you need to remember about prolonged QTC, etc. Other drugs have got no role at all. I mentioned this earlier about epigastric pain. You could consider, anti-motility, motility agents like domperidone if there's delayed gastric emptying, or you could consider, laxatives, particularly if there's associated constipation. Diet, just one slide. No, they have done extensive studies on diet. A concrete study for there's no role for milk-based, milk exclusion or anything like that in functional abdominal pain. Again, gluten, just blind exclusion is not going to be of much role. A trial of FODMAP. This is basically a fermentable oligosaccharides, disaccharides, monosaccharides, and polyols diet. They have minimal role, particularly in IBS group. And fiber-based diet has been tried. They had bit of a role in constipation, not necessarily in other disorders. So cognitive-based behavior has got a role, particularly with an associated somatic behavior. You could do that. Psychological therapy, yes. Again, the same sort of associated somatic disorders there. You could definitely involve a psychologist. And prognosis, the good thing you need to remember is the prognosis. The two long stories. They follow the children until adulthood. No, only very few had found to have any organic disease. So you can be reassured they are largely functional and they remain functional. And as I mentioned, they can have irritable bowels in later life. 30% of them persist as functional abdominal pain in adulthood. 30 to 50% usually recover within 2 to 6 weeks. If they have a poor prognosis, if there is any underlying alarm signals, as I mentioned earlier, only 2% of these patients develop any sort of organic disease in the later life. So this is again a brief algorithm. If you have a pain, try to classify them organic and functional. Look at the associated main site of pain and the main associated symptoms. Try to work out this could be functional or organic. Target the investigation and treat. So functional abdominal pain is a distinct entity and the pain is real, not malingering. It's a positive diagnosis. You can just make a positive diagnosis in your clinical practice. And it is not synonymous with psychiatric disorder. Row 4 criteria is very useful in classifying the various FAP. It's important to identify alarm signals. Structured approach is very important. As a targeted approach is very, very important investigating. Always think about the triggers. Pharmacological manuals have a very limited role. Involve specialists. It's time consuming, need regular follow-up. And these are the various references. I thank all the teachers and the parents or the children, whomever I learned from my teaching or training in Chennai and in UK centers. Thank you very much. And I will go on to functional constipation if it's okay with you all. Then we take the questions.
Yes, sir.
Yes, sir.
Okay. One second.
Himali,
Yes, sir.
unmute.
Yes, sir. So you'll be sharing the screen?
Oh,
Should we continue sir's functional constipation
Yes.
talk also?
Yes.
Yeah.
I said we continue and
Yeah,
then we
yeah,
can take
we
the
do
question.
that.
Yes, yes, sir.
Okay.
Yes.
okay. So, Dr. Vishwanathan, continue with functional constipation.
Okay. Thank you. One second. Try to open that one also. Can you see my slides?
Yes, sir.
Yes, sir.
Yes.
Okay. This is next talk, functional constipation. This is actually very important because you need to know when you are going to intervene and how long you are going to intervene. Acute less than 2 weeks, chronic more than 2 weeks. Again, there's a Rome 4 criteria there. And again, here you less than 4 years and more than 4 years you classify. Anything which has got any child which is fulfilling the 2 of these following criteria, you can definitely label them as constipation. Less than 2 defecations per week, history of excessive stool retention, history of painful or hard bowel movements, large diameter stools or large fecal mass in the rectum. And most importantly, after the acquisition of toilet skills, if they have an incontinence at least once per week, or large diameter stool that may obstruct the toilet. You can classify. Or trust me, it is happening in Indian patients also. Large diameter stools obstructing the toilet. And again, same age more than 4, the same criteria. What you are going to say is you just make sure that the symptoms cannot be fully explained by other medical conditions, and make sure that you are not dealing with irritable bowel syndrome, constipation type here. So basically, defecation is basically with constipation is defecation, also is the delay, a difficulty in evacuation, resulting in distress and duration lasting more than 4 weeks. Here, in this Bristol stool chart is useful for you all in your daily practice. Anything type 4, type 5 is fine. Type 1 to type 2 is definitely constipation, and type 3 to some extent, yes. And one important thing I want you can take a photo of this one. You can show your patients, or you can even demonstrate in your clinic. Does your child does anything of this? This was stool withholding postures. The moment a parent comes and tell you, my child is trying very hard to pass stools, the diagnosis is constipation. And immediately you can tell them, your child is trying very hard not to pass the stools because of the pain. That's what is happening. Okay, you all know that when it's going to happen, particularly during time of weaning or change in school, change in diet, etc. I'm not going to discuss that. One important thing you need to remember is most start acutely. So it's very important you intervene early, so you just prevent the chronic course. What happens exactly? A painful bowel movements, because of that there's a voluntary withholding of feces, more water get absorbed, the stool gets much more harder, again very painful, results in fissure. This results in a vicious cycle. So what is important? You make the stool soft. So you all know that majority is basically 95% of constipation is functional constipation, and they're usually very well with normal growth. Apart from fecal mass, you don't find anything in the examination. Make sure you look at the tone, spine, and gait very briefly. Anything which starts less than 1 month, or delayed passage of meconium, or developmental issues, or blood in the stools, there are alarm symptoms. Issues with the growth, severe abdominal distension, or a significant mass, or tough hair, or most important thing, please do not ignore this, extreme fear during an inspection. Usually I ask this question when there's interaction, but I can't ask this question. Always do not ignore this. There could be a sexual abuse going on. So important thing, this is one important slide. You should remember that functional constipation usually doesn't happen at birth. There is usually they have a retentive posturing, they have fecal soiling. Whereas there is usually, the sperm disease usually starts very early on. Usually there is a failure to dry, and they have a distended abdomen, they have a tight rectum, empty rectum. And they have a narrow segment with the proximal dilatation on contrast X-ray. And you don't need any investigations. A clinical diagnosis, 98 to 99%, you don't need anything. But you are basically looking for any abdominal lumps in the left iliac fossa suprapubic region. You may consider looking for thyroid screening, celiac screening, particularly in your state, a very minimum select group of patients. This is needed only, for evaluating other diseases like celiac or colitis, or manometry sometimes may be needed to check for rectal HANA inhibitory reflex and colonic transit studies, particularly for slow transit constipation. No, you need to remember, when their child is constipated, they're not going to eat anything. They're having pain. They can have soiling. They can have rectal bleeding. They can have urinary symptoms. They can have, school absenteeism. Other things you need to remember nowadays, very common problem, rampant problem is obesity. It's a comorbidity. They can have iron deficiency anemia. They can UTI. Lot of psychological issues. Management, you need to remember there are 4 spheres here: intestinal withholding, slow transit, luminal content, dysenergy. You are going to address each component. But diet, medications, lifestyle, education, please address the comorbidities. Diet, you all know that increase of fiber content. Just the child drinks water is not enough. They're just going to pee in the urine. They're not going to help actually. They need to make sure they've got a good fiber in the diet, which is approximately calculated by age in years plus 5. Make sure
Sir,
that
just 1 minute. Sir, last 5 minutes, sir.
yeah, sure. And make sure you look at the milk history. Fiber content, You just remember this: one big fruit contains approximately 2 to 3 gram fiber, and 150 gram of green leafy vegetable gives approximately 4 gram fiber. Lactulose, you could try, but the drug of choice is polyethylene glycol for both for maintenance and disimpaction. And you could consider lactose if you're unable to use polyethylene glycol. Usually, I strongly discourage use of enemas to the parents as well as to all general practitioners. Usually, you don't need enemas nowadays. If frequent disimpaction, you need to get second opinion. May need stimulant laxatives. Maintenance is very important to continue for 3 or 4 months. Do not stop the medicines, particularly when the toilet training is being tried. These are the various doses of medicine. Particularly, I want you to remember polyethylene glycol for maintenance 0.5 gram per kilo per day, approximately. For disinfections, 1 gram per kilo per day. And toilet training is, you all know that they need to be given adequate time. And most important, same time, same place, if possible, same person. You could use the same bullet like poop or kaka or papa, I think it's Marathi. And then you can use, you could utilize the gastrocolic reflex. And always Indian toilet is the best. You can see the angulation, as like a physiological one with India when you use the Indian toilet. And most important thing is education. One important thing you need to tell the parents is do not stop the medicines without my advice. Don't think this is addictive. That's a very important message. And ask them to keep a stool diary. What is important for the practitioners to know that is, you need to look at the anus and spine, but you don't have to do a rectal examination. That is not needed. Please ask for avoiding dysfunction. Ask for reassure the laxity use. Avoid antispasmodics. Avoid rectal medications. To a simple summary of constipation, more than 4 weeks, look at the red flags. It's mainly functional constipation. If it is red flags, try to look at the reasons for that. Give disimpaction treatment. Then go for maintenance. Usually they are successful. If it is refractory, please involve the specialist. They may need a rectal biopsy. They may need a rectal anorectal manometry. They are very useful tools nowadays. So please do consider celiac serology in your settings. So it's very common problem. Look at the alarm signals. We don't need to do any routine investigations. Main thing is know the medication dosage well. Do frequent follow-ups. Avoid rectal preparations. Do disimpact the stools before you go for maintenance treatment. Thank you very much for your patient listening. Thank you.
Thank you very much, Dr. Vishwanathan, sir, for such an fruitful and wonderful session. Thank you for clearing many myths regarding abdominal pain and constipation in children. It was a very comprehensive yet very crisp talk about the topic. I'm sure most of the queries related to office practice have been solved. Still, I would like to ask few questions to you. Many a times, a general practitioner or a pediatrician on getting a patient with recurrent abdominal pain or chronic abdominal pain, they do an ultrasound abdomen. And many a times it is seen that ultrasound is showing either minimal free fluid in the pelvis or non-specific mesenteric adenitis. So how much importance to give to these findings, which are seen very commonly in the ultrasound reports? And the patient will come with that we have nodes in the abdomen. That is what the radiologists have told them. So how important can we?
Very good question. Very, very practical questions. This is one of the mesenteric lymph node which we are addressing the grid module for the national IAP grid program, which we'll discuss in detail. But to you, answer the questions. In my practice, daily, if my radiologist do an ultrasound scan, 8 out of 10 patients has got mesenteric lymph nodopathy, because it's a skill of the radiologist who just picks up any mesenteric lymph nodes and they put it in the nodes. Basically, if it is localized, right iliac fossa or periumbilical, and there is no other red alarm signals, no need to worry about that. But if it is above the superior mesenteric axis, retroperitoneal, para-aortic, or a constitutional symptoms, then you need to evaluate them further with CBC or peripheral smear to start with. One important thing is short axis diameter. If it is less than 8 to 10 millimeter, do not worry. If there is no conglomeration, don't worry. If there is no necrosis, nothing to worry about that. That's a very important message. You see very commonly, particularly 10 years old, 11 years old, 8 to 10 millimeters, quite normal.
Okay, sir.
Short axis diameter.
Yes, sir. So very important point to note about the short axis diameter, and the position of the nodes is also very important. One another query which is very commonly seen, a mother of a neonate, if it comes that the child is not passing stools for 7 to 8 days and the child is otherwise active and healthy. So is it necessary to treat this neonate, and what all medications are used in a neonatal age group and an infantile age group for
So I
constipation?
think first we need to ask the breastfed, exclusive breastfed or formula fed child. That's a very important question. I'm sure my seniors teach us this all the time. An exclusive breastfed child can pass 7 stools a day, or they can pass 1 stool once in 7 days. Both things are normal. As long as, little bit of straining is quite normal in neonates, as long as it's not hard stools. There's another entity called infant dyschezia. And again, they have this sort of straining. Again, they have a soft stool. As long as it's soft stool, no need to do anything. The child is growing very well. If it is hard stool, you may consider lactulose for a short period of time. Otherwise, look for also if the child is having atopy, look for, there is any evidence of milk, cow's milk protein allergy, particularly in a formula fed child. Otherwise, I don't think they need much.
Okay, sir. Thank you, sir. Thank you for the excellent talk. Over to you, Dr. Amruta ma'am.
Dr. Vishwanathan, regarding your functional abdominal pain, I have two important queries as a practicing pediatrician.
Yes, sir.
In my office practice, when a child or an adolescent come with a history of 6 to 8 weeks with recurrent abdominal pain without the so-called red flag signs, and the pain is just pointing towards the tummy button, it is not lateralizing to any of the quadrant, can functional abdominal pain could be the diagnosis rather
Yes.
than a diagnosis of exclusion?
You're right, absolutely right. That is the message you're trying to give. Yes, it can be. Your weight, height, BP, you check it. You tell them the child is growing nicely. There is no alarm signals. You could definitely make a positive diagnosis of functional abdominal pain. There is no alarm signals. Just if at all, if you want to do something, you just do this CBC and ultrasound, and that is enough. And if it is needed, if not, you are very much convinced, you can definitely make a diagnosis of functional abdominal pain. No doubt about it.
Thank you. Thank you, sir. Another query regarding the management of functional abdominal pain. As you have already rightly said, it is a biopsychosocial model of illness. So a multi-pronged attack has to be there. You cannot have a magic bullet. But as we have seen, all the pharmacological treatment of for FAP, they have their own issues. But now there is a very good evidence which is generated from the randomized control trial by Weizmann and Romano. Romano was an earlier trial. The latest one is a Weizmann about the use of Lactobacillus rhyturi DSM 17938 for the period of 4 weeks, and it has given a very objective evidence of decrease in the stool inflammation, which is one of the which can be measured by fecal calprotectin level, also the TNF alpha 2 levels, and also the it is restoring the biodiversity of the microbiota, which has been lost in the children with functional abdominal pain. Your take home, as I know, Himali and Vishwanathan, you don't encourage the use of probiotics in any of the GI disorder, but this one of the evidence is there, and not a very robust one. But what is your comment on that?
Yeah, you had a very good question. I particularly took away the slide of probiotics in my presentation today because I didn't want. The reason is, yes, of all the functional GI disorders, there is a role for probiotic. Lactobacillus reuteri, the strain you mentioned, in infantile colic, particularly if they are exclusively breastfed. Otherwise, no other probiotic, particularly strains, have been conclusively found to have a role in functional abdominal pain, including the strain you have mentioned. Sometimes they reduce the intensity, sometimes they reduce the frequency, but not the everything actually. I've looked into the evidence, actually, it's not conclusive evidence. So at the moment, I will not recommend any probiotic for functional abdominal pain apart from infantile colic. That too, the evidence is only for exclusive breastfed child.
Thank
Again,
you.
for 3 to 4 weeks, not more than that.
Thank you, sir.
Thank you.
Yes, thank you, MS Vishwanathan sir.
Oh, Amal,
Pramod
yes.
Jog sir is waiting. Pramod Jog sir is waiting. So I request Dr. Amruta to carry forward the session.
Thank you for the time. Thank you.
Welcome, Dr. Amal Pawar, sir. So going on to our next topic, I would also like to thank Dr. Vishwanathan sir and Himali madam for the wonderful discussion. Our next topic for today is crying infant, and our moderator for today's next session is Dr. Sanjeev Joshi, sir. Sir is a president of Association of Pediatric Neurology and also a consultant pediatrician from Yavatmal. He is also EB member of Central IAP. Over to you, sir.
At the outset, I must thank Maharashtra IP President Dr. Ram Gopal, my dear friend Dr. Amol, and both the faculties and co-moderator Dr. Himali and Dr. Amruta for giving consent for being MOC at the last moment. So my warm welcome to our beloved none other than Pramod sir. आता मी प्रमोद सरांची ओळख करून देणे इतका मोठा नाही आहे. एक म्हण होती मागे जेव्हा आयफोन जेव्हा रिसेंटली ऍड झाला होता, म्हणे इफ यू डोंट हॅव आयफोन देन यू डोंट हॅव आयफोन. सो इफ यू डोंट लिसन टू डॉक्टर प्रमोद जोग सर देन यू डोंट लिसन टू डॉक्टर प्रमोद जोग सर. तर एक माझ्या ओपीडी मध्ये एक 1.5-2 महिन्याचं बाळ घेऊन मदर येत आहे, आजी आहे, रात्री 11 वाजलेले आहेत आणि 1-2 शेजारचे पण लोक आलेले आहेत आणि ते म्हणतात डॉक्टर साहेब हे बाळ किती रडताय हो, म्हणजे गेल्या 8 दिवसापासनं म्हणजे या घरचे लोक पण झोपत नाहीये आणि मी शेजारी पण झोपत नाहीये. आता तुम्ही याला कुठल्या तरी चांगल्या डॉक्टरला घेऊन चला. तर आय जस्ट रिमेंबर दॅट ओनली वन डॉक्टर कॅन मेक फुल जस्टिस to this child, a crying infant, where the diagnosis could be a simple functional infantile colic, if it is following the so-called modified Wessel's criteria, or it could be some sinister disease like an abdominal emergency or some hernia, or it could be sometimes an hypoxia, a presentation of hypoxia also. So, or it could be a presentation of infection also. It could be presentation of some shaken baby syndrome also. So, to guide about this very common clinical problem, I present to you Dr. Pramod Jog sir. Thank you, sir, for honoring our invitation.
Thank you. Slides वगैरे दिसतात ना रे बाबा?
अजून नाही.
आता
दिसतंय.
व्हेरी गुड.
फुल स्क्रीन झालं.
ठीक आहे. आवाज येतो ना? ठीक आहे. Okay,
Yes.
so I am very thankful to Maha IAP for including me in this particular program related to tips in the pediatric practice. And crying infant is a very common symptom. If we say respiratory infections and diarrhea are the bread and butter, crying infant is the cream. So it's a bread, butter and cream. Okay. And you can see the degree of Dr. Jog, which stands for FCPC, which is not an official degree, but it stands for Fellow of the Crying Pediatric Community. Okay. So I have been honored by this degree by the infants only. Okay. So remember that for babies and also for our wives, particularly because I am a male, cry is a communication. If you want to say something or pressurize the other person, in Sanskrit they say balanam rodanam balam. Crying is the strength of a baby. Okay, so our examination itself starts with crying, because at 6 to 7 months we have stranger anxiety. The baby was so playful with us while we prick the child. At 6 to 7 months starts looking at us suspiciously and starts crying, and not a single day passes when we don't get a crying child in the OPD or a telephone call, which Sanjeev said disturbs our sleep even in the midnight. So there are some causes which are either obvious or not so obvious or hidden. What are the obvious causes? These are very simple and they are not always medical. So they all start from the alphabet H. So either the baby is hungry, or the baby is hot and the baby is humid because of the wet nappies, or wants to say, hold me, my dear mother, you are not around. Okay, so all these factors are very simple to understand. or there could be some clear-cut history of injury which is visible. There are some causes which are not so obvious, like a nasal block. So the baby is brought, from the house in a crying state, and as the baby is upright in the clinic, as soon as the baby enters, the baby stops crying, and then they say, "Arey, Dr. Joke, what a great doctor you are." As soon as the baby entered, the baby has stopped crying. It means simply hold the baby with a nasal block upright, and then the baby will stop crying because the nasal congestion and the terpinates go down. And then you have to remember that cornea, sometimes there is a small little hair on the eye, and the baby is getting irritated, cannot speak out. I told you it's the communication. Babies communicate by crying because they cannot speak. Okay. Orifices like the preputial opening and the anal opening and so on and so forth, and the digits and pruritus, because these babies, infants particularly, they cannot localize. So even if there is some allergy to some medication, they cannot speak out, and that's why they keep crying. So these causes are not obvious. However, there are two important causes which are responsible for major crying episodes in babies. One of them is CNS insult, and second is the pain. So CNS insult is possibly because of two or three things. One, either the brain is getting decreased blood flow because of poor perfusion, say in shock, or there is decreased oxygen to the brain, as in case of hypoxia, or decreased glucose reaching to the brain, or the babies can cry because of pain. So pain could be localized, and that's why you have to carefully assess the child and not to stop the assessment till you find the cause. That is the only sentence that you are going to remember after this talk. So because the child is in distress, you cannot stop your assessment. And second is, of course, a non-localized pain, which could be related to the bone or to the muscles. So what we have seen till now is that the organic causes of crying are only two: a CNS insult or a pain. Now, why this pain occurs is either because of inflammation, which could be because of infection, any infection which we usually see in our OPD, or it could be non-infective, as in case of, say, Kawasaki disease, where we know that children are so irritable. It could be because of ischemia. People get heart attack because of coronary ischemia, isn't it? So that's one ischemia example. Neurogenic, or it could be psychogenic. So this is the pathophysiology as to why pain occurs. No other cause beyond these four. Remember that. So either CNS insult or pain, that you have to keep at the back of your mind. Now, what is a significant cry? As our friend Dr. Swaminathan said, and Sanjeev also referred to that, those vessels criteria. Like in an infantile colic, the child will cry 3 hours a day, 3 days in a week for the first 3 months and so on. So remember, that's okay. But if the child is crying inconsolably, that means the child cannot be quietened by anything. That is called non-consolable cry. That is a red flag. Okay. And remember, if the character of the cry is high-pitched, then you have to remember that it's a toxic child unless proved otherwise. Okay, so that high-pitched cry is very important. And never ignore a crying child which is irritable. The mother says it cries every day, but now it is irritable. As soon as I hold the child is not getting rather consoled at all. So this irritability again could be because of the pain or inflammation or CNS irritation. So we'll see certain cases. For example, there is a 1-month boy who is exclusively breastfed and crying episodically, particularly in the evening for almost 3 hours, as I said, every day. Physical examination is normal. The baby has gained 800 grams since birth and passes about 10 semi-loose stools per day. And the baby is feeding well and thriving well. So Dr. Jog is internally very, very, very happy because he knows that this basic checklist is okay, that the baby is feeding well. The growth and development is normal for the age. The urine output is okay. The bowel movements are fine, and it's a happy baby. So I can safely say that this is a baby with infantile colic. But recently, and IT sector parent came to the clinic. IT in Pune, the place where I practice, has information technology people. But usually I call these IT as inquisitive and troublesome. Okay, they usually come in Bermudas, and they may disturb you at this particular odd hour at 10:30, and then they will start asking you questions. You cannot stop answering, and they cannot stop questioning, because somehow or the other they are going to pay you. That's okay. That's fine. Let them ask also. But once what happened, just few days back, this fellow came And he say, the baby was around 3 months old and the baby was crying in the evening, came at around 8:30 at the clinic. I palpated the abdomen and made sure that nothing else is there. And a fellow, I just told him, boss, this is infantile colic. So he asked me, Dr. Job, do you want to say that colic can be palpated? Oh, I was totally floored. Okay. So I told him, of course, I am also a Punekar. So I answered him, said, sir, colic cannot be palpated, but definitely can be excluded. Okay. So remember that you have to be a little smarter than other people who want to be extra smart. Doesn't matter. So what I'm trying to tell you, it's a diagnosis of exclusion. I will tell you a little more about infantile colic in a minute. But remember, all is not well. Remember, when there are some red flags. So the child is not growing well. The child is constantly irritable, not only in the evening, and the vitals are not fitting in. Okay. So when there are these 2-3 things, you have to be very, very careful. And you are not supposed to rest till the cause is resolved. Don't send them back home. Let them sit in the emergency room. Let us come to another case. A 4-month baby brought for crying. The baby is quiet on the bed, but cries inconsolably when picked up. The feeding is very good. The weight gain is very good. The only thing is, when the baby is picked up, the cries inconsolably. What is the name given for this condition? One of our senior examiners used to ask this question. The baby is quiet on the bed, but cries when picked up. Okay. Of course, he wanted some diagnosis like, osteopetrosis and all, where, when you try to touch the cheek, the child will cry and all. That's okay. But then this is called as paradoxical crying. What is paradoxical? Actually, when you lift a child, he should stop crying, but he doesn't stop. So it indicates 2 things. One is that it's a non-localized pain. Okay. There is pain somewhere in the body, which you are unable to localize. It could be muscular or bony injury, something or the other. Okay. So when you pick up that baby, or there could be CNS irritation. Yes, Sanjeev. So it could be because of CNS irritation, like in case of meningitis. So when there is a paradoxical crying, do not let the child go unless you have sorted out this problem. Okay. Another case, 7-month baby, intermittent inconsolable crying for the last 2 days, episodic. Okay. When he cries like crazy, and when he's quiet, he's okay. Okay. Just look at the history. Yeah? The cry is shrill. I told you, shrill cry is a red flag. And the baby cries every 4 to 5 hours. For 4 to 5 hours, okay. After that, the baby cries. And baby is well between the episodes. And for the first 4 to 5 times, the baby has been okay in between. But now the baby has started becoming lethargic. There is progressive abdominal distension. And this is a very, very ominous sign. So all these things which are being told to you are ominous signs. Okay. The child getting lethargic now. So don't write it off as colic. Don't put it, oh, don't worry, this is colic, babies cry. So remember that you have to tell the red flags to the parents. A change in behavior is there. You have to also ask them to watch for urine output, activity level, whether any new symptom is developing, whether the baby is starting, vomiting. So there is additional history in this child that the complementary feed has started 1 week ago. So this could be surgical, because we have been taught that intussusception can occur following introduction of complementary feeding at 6 months. And one more thing, which of course, when we were residents, never existed, because rotavirus vaccine is relatively recent. So after the vaccination, within 7 days of the first dose, the incidence of intussusception has been reported to be always on the higher side. So be careful, ask this history. And whenever you think of something surgical, always remember obstructed hernia. I remember once, in the OPD, the child was crying, and this hernia was not apparent at all. I called my pediatric surgeon friend. He came, simply, opened and saw all the hernial sites. I told you, orifices, never forget. And he diagnosed it to be a case of obstructed hernia. And bilious vomiting, as all of you know, particularly in the newborn, if the baby is crying, then it indicates intestinal obstruction. Of course, our friend who is a gastroenterologist will agree with me that GERD, gastroesophageal reflux disease, when the acid comes up, it burns, the baby cries while vomiting, okay, while vomiting. Otherwise, a happy spitter with gastroesophageal reflux will not cry, because there is no acid, it's only milk which comes out, okay. Cow's milk protein allergy, anal fissure, he told us about constipation. So the fissure in the beginning is small, but later on, as the constipation continues untreated, it becomes a kingfisher. And as you know, that kingfisher airline also has stopped and the motion line also stops. So remember that this is the important cause of pain. So take extra efforts to undress the child and look at the anal area. Next case, a 5-month baby brought for inconsolable crying, and there is fever, rhinorrhea, occasional cough, and respiratory infection is there in the background. So this is bronchiolitis. But without hypoxia, we all know that mild bronchiolitis, babies are happy and smiling, okay? But if there is hypoxia in a child with bronchiolitis, there is distress, baby is not feeding. Here, if you find the temperature is not very high, but the respiratory rate is 80, heart rate is in 140. That means the baby is tachypneic and air entry is equal, but the liver and the spleen are enlarged, but they are not because of any disease, but they are pushed down. So have all this picture in front of you, and then you will start thinking, this child appears to have some respiratory problem. Shall I sedate? My dear friends, it is criminal to sedate a crying child. Remember that. Many of us are, fond of giving sedatives in the clinic so that the baby stops crying. But please do not do that unless you come to some diagnosis. And remember, 2 conditions where no amount of sedatives can sedate the child. One, a dehydrated child. Unless dehydration is corrected, the baby will not stop crying. And a hypoxic child, unless oxygen is given in proper amount and saturation picks up, baby will not stop crying. Remember that. Next case, 7-month, 4 kg girl, incessant crying for the last 3 months, vomits frequently. And then this baby, when you see, is a thin, irritable girl. Many tests have been performed by many of my colleagues. Many therapies have been given. All occult infections have been treated. The respiratory rate is 70. Heart rate is in 140. But there are no retractions. With a respiratory rate of 70, you expect that there should be some distress, isn't it? But we all have been told that whenever the baby is breathless, without retractions, without distress, it is acidosis. Okay. So acidotic respiration in a child who is not thriving well, who is irritable and passes a lot of urine despite less intake, which indicates polyuria, also is constipated, has severe anorexia. So there are so many red flags, and this is definitely an organic cause. Forget the diagnosis, but you have to look out for these important red flags. So do not send these children home unless you find the cause and investigate thoroughly. And in this particular case, I want to stress that growth is extremely important. We owe it to our babies to monitor the growth, and not only to record it, but to chart it so that you know the progressive pattern of the weight gain and the height gain and other things. Okay. And then the 3-month girl with high-grade fever for 1 day with inconsolable cry. Now look here, high-grade fever, I already told you, it means that there is inflammation, either because of infection or non-infection. But then the high-grade fever, that's why, a 3-month baby, you all know that these babies cannot mount inflammatory response, and that is why they cannot localize. No, so you cannot immediately get bronchial breathing, you cannot get immediately dysuria and so on and so forth, or you cannot get the next signs. So localization is not possible in these babies. So you have to do a full septic workup even if they look well. So I did the complete blood count, peripheral smear for malaria, then CRP, then the urine culture sensitivity, X-ray chest, CSF, everything normal. So workup has been normal, but fever is not going down. Of course, antibiotics have to be given because this baby is under 3 months, and this pointed to non-infective inflammation. Okay, when all the reports are normal, in spite of antibiotics, fever is not going down. And then over a period, the child had a large node which developed in the cervical area, a rash on the deltoid, which was nothing but a BCG scar which was swollen, and the child had irritability. And this turned out to be a case of Kawasaki disease, unusual to be at 3 months. But remember, this particular child was one of its case, and that's why I thought I should just put it in front of you. And this 8-month baby with fever and irritability for 2 days, with 104 degrees of fever, again indicative of some inflammation, with respiratory rate of 60, that is tachypnea, along with tachycardia, peripheral pulses were bounding, the capillary refill time was high, and the blood pressure was 90 systolic, and the fever particularly, was high. So I thought whether this is because of fever or whether it is because of the septic shock. The chest was clear. There was no respiratory distress, and the saturation was 96 in the room air. So here, with all these findings, obviously all the delegates will definitely suspect that there is some sepsis. And that's why you need to find the focus immediately And that's why a detailed examination was done. And I found that there is a forming gluteal abscess. So remember that the vitals are vital, as is a thorough physical exam. And remember, change in behavior is a parameter of seriousness. So the cause is known by the company it keeps. You all know that a friend is, a person is known by the company he keeps. So find out whether there is a problem with fever or without fever, whether the cry is consolable or inconsolable, how are the vitals. So remember that you have to try to find out the cause, and you have to try to localize to the best of the abilities. Now the first alphabet of the word try is T. That's why I have put up all the findings beginning with alphabet T. So total undressing, strip the child, look out for any bite or bruises or injury, as Sanjeev said, whether it's a battered baby or whether there is a rash of scabies. Then temperature, pulse and respiration. Remember, some of these cough syrups have aminophylline with salbutamol, and both of them, they are known to produce tachycardia. Okay, so too rapid rate. Babies cannot speak out. Infants cannot speak. So tachycardic baby will cry. Supraventricular tachycardia. Okay, again, babies will cry. And then tenderness with soft tissue swelling or fracture. That's again because of T. I have put it as 2T haddi. That means a broken bone. I remember a child who had fractured clavicle when the child was, very small, and nobody knew what's the problem. And when the baby was picked up, used to cry. And then one orthopedic surgeon from Jalgaon, he diagnosed it to be fractured clavicle, and then it was cured. And then pulled elbow, such a common condition which all of us know. So remember, following Tikakaran, that is again T, that is vaccination. See, very important, you give the vaccine and the child keeps shouting and crying at night. You know that it is because of the pertussis component in the vaccine. So this is not a serious condition like meningitis. But then remember, after vaccination, please inform them properly that the baby may have a lot of crying at night. Inconsolable cry after the wholesale vaccine has a different connotation. That's okay. But then please remember that in the house there is one WHO, that is the wife, husband, and the others. So they are very, very important, and you have to handle them properly. You have to tell them properly. Otherwise, Dr. Joke's practice is gone. They will ask, "अरे ये कौन डॉक्टर है? साला कुछ भी करता है, इंजेक्शन कैसे लगाता है, मालूम नहीं क्या, नेक्स्ट टाइम इसके पास मत लेके जाओ." So once they say that don't take him to Dr. Joke again, your practice is gone. So be careful, handle properly, and tell them and look at the family and give them advice accordingly. Anyway, continuing with that T, a tense fontanelle, I need not tell you, it's along with shrill cry when the child is quiet. You are not supposed to examine the fontanelle when child is crying. You all know that. And tight neck, meningeal signs may be present, may not be present in an infant. So these two for the diagnosis of meningitis may not have much meaning. And then terenaina, the eye. I told you, hair in the eye, a foreign body in the eye. Evert the eyelid, a foreign body which is hidden in the lid. Some of our ophthalmologist friends, they do what is called as fluorescein staining. And you have to rule out corneal abrasion. See, lacrimation, blepharospasm, or conjunctival redness may not be present. Only they can have excessive crying. So examine the eye. And for the physical abuse, you have to rule out retinal hemorrhages. And our friend, tympanic membrane. Remember, you have to use otoscope for diagnosing acute otitis media. And you have to examine twice the number of ears as the number of patients in OPD. So if you have 30 patients, you have to examine 60 eardrums. Obviously, it is because every child has 2 tympanic membranes. That's fine. In the beginning of my practice, I did not have otoscope. So I remember I had used something which looked like an otoscope. That's different. But in the months of December, many our NRIs, they come from US here and there, and they are never satisfied unless you use an otoscope. So please use it and tell them that the eardrum is normal. Okay, because diagnosis of acute otitis media rests on examination of eardrum. Okay, and then remember, continuing this top to toe exam, I told you about tachypnea. We have seen that in that case. When you palpate the tummy, be gentle and the tender abdomen. Appendicitis may not come in the right iliac fossa in an infant. It could be periumbilical. Okay. And then the pattum palpable bladder, indicative of obstruction. An obstructed inguinal hernia. And this totaram. Totaram is another name for a male genital where there is zips, that is zip in the preputial skin. I'm sure our friends have witnessed this particular condition. When the mother is putting up the zip, it goes into preputial skin. And then balanoposthitis. So I told you that examine all orifices. And torsion testes, I will just tell you a little more in a minute. And then when you examine per rectally, the fissure and also the intussusception. Okay. This very important. The totaram, that is the name I usually use for the male genital, and around. So look out for pus from the orifice, that is prepucial opening. Urinary tract infection can be diagnosed. Perineal rashes, as in case of nappy rash, could be irritating the child. It could be fungal or elsewise, or it could be perianal redness following diarrhea. Okay. And one important point is, particularly if a child is developmentally challenged or has some problem like hypoxic ischemic encephalopathy, okay, you have to be very, very careful. I always feel, as to who listens to these babies who are, deaf. They might be crying internally. I really don't know. But then, I thought I must put this thought in front of you. And it can be an early indicator of cerebral palsy if perinatal history is significant. So children with CP will cry in the infancy, okay? And that's why you must remember that the onset duration and the progress, ODP, is the OTP. In the bank transactions, we get the OTP, which finally takes us to the payment. So this ODP is the OTP. So you have to look at the onset. If it is with cold and cough and URI, otitis. If it is pain first, followed by fever, followed by vomiting, then it is appendicitis. Okay, the sequence is important. So there are many things in the history and the onset and duration and the progress. Of course, conditions like anomalous origin of the left coronary producing, severe chest pain in an infant, and gone are the doses of, congenital syphilis. We used to get children with, pseudo-paralysis with periosteitis and scurvy and osteopetrosis, which I just mentioned, though not very common. You have to keep them at the back of mind. And I said I will tell you about torsion testes. A painful red scrotum is a surgical emergency, and severe testicular pain, nausea, and vomiting would be there. And then the lie of the testes from vertical, it will become transverse, and the cremasteric reflex will be absent. And the necrosis is likely after 12 to 24 hours, and which can occur even as little as 2 hours. So remember, this torsion testes has an early neonatal peak, and then of course there is another one around puberty. But be careful, and that's why use all your senses. Listen to what mother is saying. A mother who appears irritable, continuously speaking, telling about the baby, you feel, what is this now? Enough of it. Always remember, these are the mothers who are giving you some clue. Never ignore those irritating mothers. Okay, LISTEN is the word which has 6 alphabets. But if you reshuffle, then the new word comes, and that is SILENT, and that is silent. So you have to be silent at the back of mind when the baby is crying. Okay, that's an art. So look into the eye of the child. Of course, it's very difficult to look into the eye of the child, because the child knows that Dr. Jog is going to do tuchuk injection, so he will start crying. So you can look to the eye of the parents. Of course, looking at the people who are around at that time. But you have to just give them confidence, okay, and speak out, reassure them, particularly for colic, that see, this will be all right within 3 months, don't worry. And remember this word speak, and all those alphabets of this word are to be reflected in your speech. Okay, so what is that? Sincerity. S, that is P, is your personality. E is your experience. A is your authenticity, and K is the knowledge. So once the patient is confident that Dr. Jog is a senior fellow, now his hair are gray, and he has experience, and everything is fine. Okay, whatever he speaks is sense. Then only they are reassured. Okay, very, very important. And as we were discussing about some aspects of treatment, remember this word placebo. So some of these therapies like positioning, if you hold the child up with the pressure on the tummy of the baby on your shoulders, that burping can release little bit of gas. Lactobacillus reuteri in infants who are breastfed may be of help for infantile colic. Antispasmodics, as far as possible, avoided. Carminatives, limited role, only placebo. Ethyl alcohol, that is our alcohol, which is present in gripe water, and some of our friends found that children sleep not because of anything else, but because of the ethyl alcohol in gripe water. Body shape, which is seen in some formulations starting with the alphabet B, and then others. So remember, the value of most of these is like placebo, and that's why this is the slide for that. And of course, when a patient calls you at 10:30 after this program saying my child is crying, no sedatives. Okay, tell them, see, in my practice, I only prescribe water on telephone. If somebody asks for fever, I tell them tepid sponging with water. Cough, warm water with honey. Loose motions, water with salt, sugar solution. Okay. So for even constipation, plenty of water. So apart from water, there is no other advice which I give on telephone. Anyway, that's a trade secret. Doesn't matter. But no sedatives. And then, my dear friends, that I remember that history, physical exam, and the lab tests. That is number one. Number two, find out whether it is non-organic, simple, trivial cause. Just reassure, like in case of colic. If it is organic, find out whether it is because of fever or surgical. Okay, so this is very simple. So some take-home message is very simple. Comprehensive history and expanded physical exam will diagnose most of the diseases. Okay, when you see a red flag, do not let the child go away. Keep him in the clinic. Infants who do not have the red flags, but they continue excessive crying, observe them in the emergency room or your clinic, repeatedly assess them. Do not let them go till you get the cause. I told you this is the most important thing. Many times what happens, we give them some antispasmodics, some carminatives, and tell them, okay, go, don't worry, this is fine. Don't do that. And then colic, as I told you, is a very common diagnosis, but it's a diagnosis of exclusion. And in an emergency setting or a crisis setting, it should not be given as the first diagnosis. And that is why do not diagnose colic very frivolously. That means just casually, okay? So unless there are multiple recurrent episodes in an otherwise healthy, thriving infant, do not diagnose it frivolously. And most of the children, as I told you in the beginning, they are handicapped by not having the ability to communicate. They cannot speak out, okay? So tap into the parents, take a detailed history, and this history taking depends on the time that you have and of course parents' IQ. So both these things could be tough because some of my colleagues who have OPD running into hundreds hardly have a time to go in the details of the history. And sometimes if you start going in the details of history, the parents' IQ is another bottleneck, okay? And remember not to neglect the red flags. Neglected red flags will trouble you later on, okay? So be careful, note down. Remember that we need to have our normal cortical function. Investigation labs, USG, X-ray, all of them will not give a diagnosis. It is there what is between your ears. That means between the two external ears, that is your brain, that will give the diagnosis. Okay. Remember, my dear friends, we all cry. Sometimes we ourselves, we cry inconsolably. Many times we cry inside, unlike these babies who are so expressive. So, my dear friends, I will end with this particular Hindi song, Rote Hue Aate Hai Sab, Hasta Hua Jo Jayega. I have completed the line in my own way. Us pediatrician ka hi practice badega. So see that the children coming to you in a crying state, go back in a smiling state. Thank you.
Sir, thanks a lot. Very comprehensive, with lot of sense of humor, with lot of take homes, and with lot of tips in the office practice about a crying infant. So I had nothing to add more, but just to add one important issue in a child who is otherwise normal and to whom we can label as infantile colic, about the maternal and the baby bonding, like the stress element in the mother, the work stress, and it could be some postpartum depression also or something like that. So how you manage this maternal issue which are reflected as infantile colic in that baby?
Yeah, you're right. Actually, I was involved in one of the studies, and that was called as, maternal depression. Okay. And there was another syndrome, in fact, in textbooks, it has been very well described, separation anxiety. Whenever the mother is not seen by the child, many times, these babies, they do cry. Okay. And it's a very, very difficult question, Sanjeev, to answer. But then, of course, these babies need a caretaker. Okay. They need cuddling. I told you that, these babies have a need to be held. Okay. So that is an unmet psychological need. And whenever there is someone in the family who is a support for this mother who is unfortunately under some psychiatric problem or some depression, I think there has to be some caregiver, maybe her sister, or maybe somebody like a grandfather or a grandmother who would, become a parent figure for this particular child. Of course, there could be some other psychological inputs by our other colleagues. I will welcome them. But to the best of my knowledge, I think this separation anxiety or maternal problems have to be handled with a lot of counseling, reassurance, and having some other caregiving figure in the family. I think so. Thank you.
And sir, another about the treatment part of infantile colic. As you know, the Cochrane analysis is favoring the use of, again, I'll write to you DSM 17938 in the breastfed baby. But what is Jogren's analysis about DSM 17938?
See, actually, I will tell you this. I know my analysis is, particularly when a baby comes to you for infantile colic, reassurance is the first one. Okay.
Yes.
Some of these studies on Lactobacillus reuteri, mainly, of course, were done abroad. The flora of our infants
There is one study with Gulati in India also.
Yes, some of these studies are there. The
Yeah.
sample size is always a problem. Anyway,
Yeah.
just to cut the long story short, it should be used as an adjunct. Okay, adjunct means a supportive thing to
Yes.
the other reassurance and other placebo things that I told you. It should be an adjunct. And what I usually do in the Jogren analysis, if a patient doesn't listen to my reassurance, then I prescribe it because it is basically very costly. So he let him suffer in the counter of the retailer. So usually I prescribe them so for 3 weeks, and it is better to keep them away for 3 weeks. Actually, in the beginning of my practice, I was going to label my clinic as Muddat Ka Dawakhana, the clinic of 21 days, because at that time typhoid used to take 21 days to settle. Cough, as we all know now, takes 3 weeks to settle. Diarrhea initially also, in a malnourished child used to take very long. This colic also takes long. So, but then my wife told me, don't be extra smart. Give only the name of Dr. Pramod Jokes Children's Clinic, and that should be the end of it. Anyway, so for 21 days to keep the parents away, that is the best treatment. So you tell them, see, you come after 21 days. So what is so magic about 21 days? Nobody understands, but it's okay. So you can just keep them away for 21 days. By then, if the child turns 3 months, you are happy. So the headache of these IT sector parents is gone, isn't it? Thank you.
Yes. Thank you, sir. So just to summarize about the crying infant, the 10 commandments the promoter has bestowed upon us to all the practicing pediatrician and to all those eminent pediatrician, those who are present on this virtual platform. The number one is the pattern of the cry, recognizing pattern of the cry, a paroxysmal cry with a starting and a clear-cut end and normal in between, easily consolable and with a diurnal variation. Less like to be an organic, could be more of a functional type. But if it has got an inconsolability, it is a monotonous cry, like a shrill cry of a meningitis or intracranial bleed, a monotonous sort of cry without diurnal variation, more like to be an organic one. The second commandment is listen to the mother. सर हा कालपर्यंत असा रडत नव्हता. आज याचं रडणं आज काही वेगळं आहे. इट टेल्स यू लॉट, as Professor has already told. Assessment of growth. The third commandment, if the baby is faltering of the growth, then there has to be some organic cause. Most common causes are feeding, GER, and of course in a cow's milk child, the cow's milk protein intolerance. Did you look at the eardrum? Of course, you have to look at the eardrum. Okay, did the baby have GI symptoms? Did you ask the history of GI symptoms? Did you undress the child? The sixth commandment of promoter, I think the significance of undressing, sir has already told to you. Have you checked the conjunctiva? Or did you look at the fundus? Then, did you notice that the movements are causing the paradoxical sort of things? Organic, not functional. Did you check the child is hypoxic? The ninth commandment. And how is mother psychologically stable or not? That is all the 10 commandments from respected Jog sir. I think Ram Gopal has to add something. So take these 10 commandments home, all dear friends.
Just one comment after Dr. Ramagopal.
Sir, I just want to
Come,
ask
Gopal.
you one logical question. I have not seen any infant pant with the jib, where you had said that there is an pipis injury. So can you just explain how it occurs?
No, I will tell you what happens. The actually this is not very true for the infancy.
Yes,
but
that is
this-
what exactly
yeah,
was
yeah.
my point.
This more for the, little older child, where the child is going to the school and in the hurry, the pant is put up and the mother pulls up the zip and it gets into the prepuce. Of course, as you rightly say, not for the infants in the first year, but then one has to be careful, otherwise, of course, that becomes very obvious because after putting the pant itself, the child starts crying. But then, these the instruments like puckered and others, I have kept it in the clinic with a screwdriver, because with the tip of that, then I can, take up the zip and then the preputial skin is relieved. So now these days, of course, the days have changed. The pattern of clothing also has changed. But then one has to just keep it at the back of mind. Probably it was, as you rightly say, infancy, probably not the cause, but then maybe little older child. Thank you for pointing it out. Yeah.
Thank you, sir.
Just one comment. Dr. Pramod, sir, I enjoyed your talk. Very nice, very superb. And just want to know about this probiotic, Rotary. As Dr. Chanji showed, yes, we can use it, but nicely, you tell the parent family first, there's not much medicine you can use, you can reassure. Then you can try this medicine. And after a few months, the infantile colic is going to go away anyhow. In 3 weeks' time, the child gets better, you can take the credit having prescribed the medicine. If it doesn't go away, you can tell, well, look, I already told you it will not go away. Fine, full stop.
Right.
Thank you, sir.
Sir, I would like to share one of this infant crying babies. Almost 25 years before, I was about to finish my OPD. As I almost finished, I was about to move out of my clinic, and suddenly my regular patient, 3.5 months, she was just crying. That my baby is crying like anything. It was an hyperacute presentation. And the only word she used that, हा पहिले असा कधीच रडायचा नाही. आधीच मी इरिटेबल होतो, पण तरी मी काहीतरी आता एक्झामिनेशन करावं, पाल्पेट करावं, हे करावं, ते करावं. आणि आय जस्ट पुट माय स्टेथोस्कोप ओवर देअर. So it was a classical SVT rhythm, and that too with shock. The child was hypoxic. 25 years before, I did not have access to adenosine. So I just called my physician friend, who just shocked that baby in my OPD only 3 times. And today the child is perceiving MD pathology.
Very good. Yeah.
So thank you, Maharashtra IP. On behalf of Maharashtra IP, I am extremely thankful to both the speakers, Honorable Pramod Jog sir and Dr. Vishwanathan, my colleagues in EP. Thank you, Dr. Ram Gopal sir. Thank you, Amol, as always there. I think without Amol, nothing can function in Maharashtra IP. And thank you, Dr. Amruta. If at all, Amol, you want to add anything? And Amruta, to sum up, please.
Sir, before that, just sorry to interrupt you. There are a few questions in the chat box.
Yes.
So
Okay.
one question is, for which age PEG can be used for constipation?
Yes, sir.
Very good question. Yeah.
Yes, sir.
Like basically, you can use from usually, you can use definitely more than 1 year. Less than 1 year, you can just go with lactulose, and you can just slowly, gradually increase it. If it doesn't respond, nothing wrong in trying polyethylene glycol. I have tried even for more than 6 months. There are ready-made solutions available also. But when you are going to use that, try to use it a bit more carefully. Usually, more than 1 year is safe to use, but nothing wrong in using even less than 1 year if there's a need for it.
Okay. So next question, is there any true role of milk of magnesium or chromaffin now when we have PEG is freely available, especially in view of safety profile, they're asking?
Very good question. Excellent question. Because, if you look at this chromaffin, they have this combination. One is chromaffin plus, one is chromaffin. Chromaffin plus has got sodium picosulfate in it, whereas chromaffin, for example, just saying that because since you asked this question, chromaffin has not got the stimulant in it. So you need to remember very carefully. If you use the word loosely, chromaffin plus might have been effective because it has got a stimulant in it, whereas chromaffin might not have helped it. So liquid paraffin as such not very useful, or milk of magnesia. In fact, milk of magnesia itself can cause constipation to some extent. But I do use liquid paraffin when I have a child who has got adhesion, some constipation. It has got some adhesive lysis role also. But otherwise, as you rightly mentioned, in this era, polyethylene glycol is the number 1 drug, number 2 drug, and number 3 drug. And rarely I use lactulose, particularly in young children.
Thank you, sir. The next question is drug of choice for disimpactation for first episode of constipation.
It's polyethylene glycol. The most important thing is you start
dose.
around 1 gram per kilo per day. With different formulation has got different strength. Some has got, for example, a jar comes, it says 1 cap, or it says, it contains around 17 gram. It marks 8 gram. Another says in 10 gram, 25 ml contains 10 gram. So you need to look at each formulation, whether it's a sachet, whether it is a powder, whether it's a jar, or whether it's a solution. And you work out dose per kilogram per day and you build it up. And just 1 gram per kilo for 2 or 3 days. If not working, then 1.5 gram per kilo for 2 or 3 days. Usually by 5 to 7 days, disimpaction would have happened. Then you go for maintenance dose. And again, disimpaction, when I mean disimpaction, it's only polyethylene glycol. And I tell you honestly, as a pediatric gastroenterologist sitting in a tertiary center, seeing difficult constipation in the last 12 years in Chennai, I hardly have to use enema maximum 10 times. With the advent of polyethylene glycol, I hardly have to use enema. In UK, when I was trying, actually, you won't believe this, guys. I went to the theater to the manual evacuation under general anesthesia for few patients. But that does not happen here. But still, the rampant constipation is still there in our country. But polyethylene glycol is a very good drug, and you can use orally 98 to 99% of time. Oral disinfection is enough. Rectal route is hardly needed.
Himalika, would you like to add anything? Himali, unmute yourself.
No, sir. As sir rightly said, polyethylene glycol is the first line therapy for constipation. Even we also use the same thing.
And the minimum age is above 1 year. That is okay.
1 year, yes, sir. Yes.
Okay.
Less than 1 year, usually lactulose is recommended.
Okay.
There was one question, the duration of the treatment, about the duration.
Himali, duration?
Sorry?
Duration
Himali,
of the
duration.
treatment.
Yeah, duration, usually I tell like this. Okay, I tell you an important secret. When they come to you, the history of constipation of 3 months, I tell them your child usually need around double the time, just 5 to 6 months, approximately. Well, that's the basic principle. But sometimes, I've been using polyethylene glycol for a child now nearly 6 years. But the moment I stop, it gets a problem. But I use many minimal dose. You can always reduce it. Nothing wrong in that. You give a plan to them. So acute constipation, if you start early in 2 weeks time, you'll be able to get out of it in 1 month time. More than 3 months, you may have to use more than 3 months duration. You may have to use it 4 or 5 months. But try to reduce it, or try to use alternate days. Try to go for 2 or 3 times a week, something like that. And more importantly, you tell this one important thing to them. Well, if you are going to make your child healthy food, I'll be taking the medicines off. If not, this will be the food for the child.
Yes, sir. Very important point that apart from giving medications, dietary modification is very important, because without dietary modification, this is not going to help much, not for a longer time also. So both the things you have to explain in detail. Only then the constipation gets resolved. An
important thing is nowadays, you all know that rampant obesity. I tell them, just get your child on the road for 30 minutes, 40 minutes, do whatever he wants to do, but let him not sit on the couch, because the physical activity itself is going to improve the bowel movement. Obesity is rampant. That is an important reason for reflux, gastric reflux, and constipation. Please address that.
One more question. Thank you. One more question is dose of lactulose in less than 1 month babies.
1 month.
Yes.
Yeah, usually dose is 1 to 2 ml per kilo per day. But I think, as I told you, constipation if in a neonate, please look at red flags. Please evaluate carefully. If you are convinced, anything which is early onset, less than 1 month, less than 3 months, if it is organic, please make sure it's not organic. If it is not, if it is soft stools happening less frequently, that's okay. Nothing need to worry about that. But if it is hard stools really troubling the child and of course the family, then you can use 1 ml per kilo, something like that. But again, you can adjust those. Sometimes you need just only 2 ml once a day, sometimes 2 ml twice a day, sometimes 2.5 ml twice a day. You can address it. And usually the good thing is, if it is neonate, usually be able to come off lactose in 3 weeks to 4 weeks, not more than that. Usually they don't need for a long time, if it is not organic.
Those are the only questions.
No, I told no. Functional constipation is much more interesting than functional abdominal pain. If you see more questions, more for functional constipation. And that is the reason I wanted to finish the topic.
Yes.
I know that because functional abdominal pain, still people will not. I want people to make any of this functional GI disorder as a positive diagnosis. Don't hesitate. If you make it, it will be easy for you to follow up the children. No, I know I have seen this child first. I have done a detailed examination, history taking. I made a positive diagnosis. So you'll be very happy. Next time you won't be spending too much time on this child.
Actually, most of the time, the constipation is also associated with a fissure. So, any role of a local anesthetic agent or a calcium channel ointments, local
Very good
application
question, sir.
before
Very good
before
question.
passing stool and after passing stool.
No, very good question. Don't use any sort of calcium channel blockers. I don't use them at all. I tell them very simply, if you have injury on your head, you can put a plaster, you can keep rest. Unfortunately, if you have a fissure, daily the stool has to pass through that way only. The only way you can give rest is to make the stool soft so that you can allow enough time to heal. But yes, you can give it, but you have to tell them that the stool softness is the main thing. You can apply local topical ointment, which is Dignagen based jelly for 5 to 7 days twice a day. I definitely do not recommend anything which is contain calcium channel blockers. It is not needed nowadays, sir. Because nowadays we have got better drugs, which makes the stool soft easily. And we will able to treat constipation easily. But previously we did not have that. So nowadays we don't have to use it.
Yes. Thank you, sir. I would like to thank. That was a wonderful talk. Definitely very exciting and very, very knowledgeable and wonderful tips by all the experts. To start with, I'd like to thank Dr. Ram Gopal sir, Dr. Amol Pawar sir, Dr. Gravita Raika from MahaIP, today's expert, Dr. Vishwanathan sir, Dr. Pramod Jog sir, today's moderator, Dr. Himali madam, Dr. Sanjay Joshi sir, and today's guest of honor, Dr. Ajay Srivastava sir. I would also like to thank MMC Observer Dr. Abhishek Kothwale and our wonderful delegates, more than 350 plus, for the wonderful making it such a successful by joining in such a large number, and Pallavi madam from MahaIP for the wonderful support system. Anything?
And may I thank Dr. Amruta Bhaviska. Thank you very much for hosting the program so well. And of course, Dr. Amul for the invite and the Maharashtra IP. Thank you very much. It was really nice talking to you all and an elite audience. Thank you very much. And also a great opportunity to listen to again the legend Dr. Pramod sir. Thank you.
And sir, sorry for a small technical glitch which occurred for 1 minute.
But we were able to join immediately, sir. No problem at all. Thank you.
Thank you, sir.
Thank you all. Thank you, sir.
Thank you.